Aloha mai kako. Good evening, everyone. I want to acknowledge that this is land where the Native Hawaiians lived and raised their children, and we thank our ancestors for caring for it, and we thank the University of Hawaii for continuing the spirit of Aloha Aina and Aloha Kipa here today. I'm Dr. Nalani Blaisdell, and I'm a proud graduate of the John A. Byrne School of Medicine, and I went on to do my residency program at UCLA Neuropsychiatric Institute. Today, I'm very pleased to introduce Dr. Regina James and Kathy Oriana from the American Psychiatric Association. The topic today is diversity and advocacy, why they matter now more than ever. Diversity is on all of our minds, especially in the wake of the recent Supreme Court decision and what the eventual consequences will be for educational institutions. Dr. James is also a graduate of the University of California, Los Angeles Medical School and Residency Program. She's Deputy Medical Director and Chief of the Division of Diversity and Health Equity at the American Psychiatric Association in Washington, D.C., after spending many years at NIMH as Director of Clinical and Health Services Research.
Okay, we have a very intimate crowd here. Loving it, loving it, loving it. All right, I'm just gonna close this so I won't hurt myself. Okay, so what I'd like to do is sort of talk about diversity, equity in the context of advocacy and really sort of give a background of why things are the way they are, why we're seeing these inequities. I think understanding some of the history kind of helps us understand and appreciate that. I think it's very important as future leaders in psychiatry, right? I know you're medical students, but still future leaders in psychiatry, that it's important to understand sort of the roots of sort of what we're seeing today and how you might integrate some of this information that I'll share as you in the future will be working with your patients. So as Dr. Blaisdell mentioned from the American Psychiatric Association, so part of the APA mission statement is to promote universal and equitable access to the highest quality care for all people affected by mental disorders, including substance use disorders. So key here, obviously, access and quality care, but I'd like to underscore the all people affected by mental disorders, including substance use disorders. Before we talk about advocacy and health equity, just wanted to get a couple of words down so that we're all on the same page in terms of nomenclature. I'm going to intermittently use either law or policy, so just to make sure that we're clear on the definition. So law is essentially an established system of rules, right? An established system of rules that members of society must follow. A policy is essentially the protocol or procedures to implement the law. It ensures everyone is compliant and conforms to the law, and typically is reflected with money, resource allocation. And the important part that you'll hear from me as well as from my colleague Kathy later, policy ideas can come from outside the government or interaction between the government and the public, and that would be you. So health policy affects health outcomes. Some of our nation's greatest health successes actually would not have been possible without policy changes. And so I'm going to actually highlight just a couple to give you a sense of, as I call it, the power of the pen, policy, and how that can actually impact health. It plays a vital role in creating conditions that improve our health and addresses not only the medical factors, but the non-medical factors or social factors that are fundamental to providing health for all. So these are just, again, select laws that impacted mental health and access to care. So Community Mental Health Act of 1963, sure, none of you all were alive during this time, but that was about 60 years ago during President John F. Kennedy's administration. And the Community Mental Health Act was essentially a way to, I guess, deinstitutionalize the treatment of those with mental illness. So the Community Mental Health Act promoted having clinics in the community so that people would not have to be treated in institutions for mental illness. The Mental Health Parity and Addiction Equity Act of 2008, that was during the George Bush administration. And that is essentially saying if I'm coming for mental health care and someone's, and I'm also being treated, let's say, for physical ailment, I broke my knee and it's mental health, that basically the insurance should cover, I should get, the same coverage and the same reimbursement, and it shouldn't be less because it's a mental illness versus a physical illness. So there should be parity between mental health, addiction, as well as other forms of physical health issues. And then the Patient Protection and Affordable Care Act in 2010 was during the Obama administration. And that essentially was an opportunity or a law that was passed to make sure that A, there are more people who are covered with health insurance, B, that we wanted to, at least many states did, expand their Medicare, and C, also innovation models of how to save money with the healthcare system. So later I'm going to talk about some of the outcomes of those laws, but again, just talking about policy and health are very important. And health in all policies is important. So it's not just when you do an educational policy, it's just about education. But what is the impact of health? When you do a policy about smoking, what is the impact of health? So all policies, you should integrate health considerations into policymaking across multiple sectors if you really are interested in improving the health of all communities and advancing health equity. So what exactly is health equity? Does anyone have any idea they want to share? What is health equity anyway? I love when I ask a question and all of a sudden something becomes important on your lap, or I'm like, God, what time is it? That's okay. I won't volunteer anyone. So what is mental health equity? So it's a state in which everyone has a fair and just opportunity to attain the highest level of mental health. Keywords: fair and just opportunity. So in order to achieve equity, it requires society to, one, understand and address historical and contemporary injustices, and also to overcome economic, social, and other obstacles. And we all know what those social and economic obstacles are. That's when we start talking about the social factors or the social determinants of health, really overcoming and addressing those issues. So the historical part. So history has shaped our society in many ways with direct implications for health. Again, talking about social, economic, and environmental conditions shape health, and understanding that it's not just a product of contemporary circumstances. So when you see someone who lives in a certain zip code or a certain neighborhood, and you're seeing them, okay, this person is poor, and you already have preconceived notions of what that means. I think it's really important to understand the context historically, or the root causes of why certain populations or certain communities are where they are and why they're facing inequities. So it's not just a product of some contemporary circumstance, but is deeply rooted in the history of populations and communities through their progression here in the United States. And understanding history sheds light on the roots, of course, of present-day health inequities in the US. So the social, economic, and environmental conditions. We've all been talking a lot recently, although I've been talking about it for many years, but talking about recently the social determinants of the social factors that impact health. So this is just a short summary. So we're talking economics, we're talking the neighborhood that you live in, education, literacy, food, like food insecurity, community and social context, social support systems, discrimination, stress. All of these things impact health outcomes, actually more so than other issues. These social factors have a significant impact on your health outcome. Now, again, like I said, I've been doing this for a number of years, but this concept around social factors impacting health, it's not new. This is 120 years ago, W.E.B. Du Bois documented in his publication, The Philadelphia Negro, where he essentially did a study and showed that a person's health condition was reflective of their neighborhood or residence. So looking at Black Americans in Philadelphia, if they lived in the Fifth Ward, which was the worst part of the city, and where the sanitation was not really great, they had higher death rates. And if they lived in the 13th Ward, where the homes were more stable and streets were clean, they had better health outcomes and better better outcomes and rates. So this is 120 years ago. I mean, let's just go back even further with Rudolf Virchow when he did his landmark report on typhus epidemic. Again, Virchow noted that the effects of the epidemic were really concentrated among the poor, with bad nutrition and bad housing, rendering them vulnerable to disease. So it's more of a social than a medical problem. And then in 2005, of course, the World Health Organization really defined the social determinants and these medical factors and how to really overcome or recommendations to really address them, which is, improving where you live, learn, work, and play and pray, tackling inequitable distribution of power and money, and measuring and understanding these problems. So again, I just wanted to just underscore, we talk a lot, I know, about social determinants of health. I know that it was actually a platform of our prior president of the APA, Dr. Pender. She focused on the social determinants of mental health. And these have been issues that have been plaguing medicine and psychiatry for years. And several studies support, again, that the social factors can be more important than healthcare or lifestyle in terms of influencing one's health. But inequality in the US is not only rooted in these social factors, but also in behaviors, beliefs, policies, and these inequitable and harmful policies date back to before the country's founding. And so that's why I have the 13 colonies, how at the time when the US was really being pulled together. So let's talk about some of the inequitable and harmful policies that date back to before the country's founding. And I want to sort of just quickly breeze through some of the policies and laws that impacted different racial, ethnic groups and communities, and how that is truly part of the root of some of the inequities that you see today. So when you keep in mind, in the back of your mind, these social determinants where people live, learn, work, and play, and then think about some of these things that happened during the time, the 13 colonies, and then, manifest destiny and spreading out across the US. Think about how these things that were happening then, these policies, these laws, legislation, how they impacted where people live, learn, work, and played. So let's start in the very, very beginning, Virginia colonies. There was differential treatment of Black and Indigenous people from whites. So in the 1600s, leaders of the Virginia colony actually began to pass laws. Here's that power of the pen, and established practices that sanctioned differential treatment for freed servants whose origins were in Europe. So there were indentured servants who came from Europe who had a certain amount of time where they had to do work, and then they were able to be freed and buy land. Black and Indigenous people were forced into categories separate from white, and it was at this time that this inegalitarian society structure was really being put together. Leaders began looking at physical differences to say what group is different from the other group, therefore one group is superior and one group was inferior. So this is dating back to the roots, the Virginia colony in the beginning, 1600s. You talk about live, learn, work, play, literacy, right? Education. 1700s, 1800s, Southern states enacted anti-literacy laws prohibiting anyone from teaching not only enslaved people of color, but free people of color to read or write. So in terms of different groups, I'm start with Black Americans and some of the laws that enforce inequities. So we had something called Black codes or Black laws. So even despite the emancipation of enslaved persons, there were Black codes or Black laws that essentially detailed where and when and how formerly enslaved people could work and how much they could make. And this was, again, to sort of try and keep the things the way that they were, because it was, antebellum, and they wanted to make sure that enslaved people could still be controlled through these black laws or black codes. And then if you're familiar with Jim Crow laws, those were the segregation, black only, white or colored and white only signs that you'd see on bathrooms or in parks or in libraries, different drinking fountains, things of that nature. Again, and then there was redlining. This is a process in which loan corporations guided lenders to basically buy or not buy homes in certain areas. So they had a map. It was literally a red line drawn around certain areas, and they were denoted hazardous if they had a high concentration of communities of color, and non-hazardous. So if you were a person of color, then you were sort of shown homes in this area versus homes that were not denoted by this red line of hazardous communities. And so, of course, this led to this difference in where you live. So the property values in certain areas were low. That means taxes were low. That means the quality of the schools were less. You had limited access to equitable health care. So these are laws that are put in place that really sort of set up inequitable treatment, set up inequitable where you live, learn, work, and play. And not necessarily their health was a result of contemporary consequences. So in terms of indigenous people, manifest destiny, right? Manifest destiny was a thought that the colonizers felt that in addition to those 13, states, it is our destiny. We are manifested to move more westward and claim more land. It is God-given, so to speak. And so in that mindset, in that time period, other laws that were enacted, the Indian Removal Act, against the backdrop of this manifest destiny that was occurring in the 19th century, indigenous people were forcibly expelled from their ancestral homelands to make room for colonizers under the banner of the Indian Removal Act. This was a law leading to tens of thousands of deaths during the grueling relocation process. Again, this was a law. The Dawes Act was a legislation in 1887 that further strengthened the hand of government and encouraged taking of the land from the Native people by the colonizers. Again, all laws that are leading to community and population isolation, inequities, etc. So manifest destiny in relation to the Latino population, again, because they were moving westward, so they were going southwest and west, and so that basically had an impact, a deleterious impact on the majority of the Latino population that remained in those regions. And there were social contracts, quote unquote, agreed on by treaties, but not fulfilled. And so property rights were challenged by lawsuits, again, resulting in widespread disposition of Latino land. Asian population, there was the Chinese Exclusion Act. The Chinese Exclusion Act of 1882 was the first US law to prohibit immigration to America based solely on race. In 1924, the Immigration Act. So the Immigration Act, additional restrictions were extended to other Asian populations with the passage of this act, which simultaneously, while they were restricting other Asian populations, they increased immigration opportunities for people from Northern and Western European countries. Again, this was legislation. And then the World War II internment camps, of course, over 100,000 Japanese Americans were placed in internment camps despite the fact that they were US citizens. And then here, Native Hawaiians. How many of you heard of the Resident Alien Act? Okay, the Resident Alien Act, this was in 1850. It gave foreigners, those who were moving here to Hawaii, the right to buy and own land in Hawaii. So the concept of land ownership was not really a thing until there were a lot more foreigners who were coming here to work. They didn't want to just lease land, they wanted to buy land, they wanted to own land. The Kuleana Act of 1850 brought this Western concept of land ownership, and it enabled the Land Commission to award parcels of land to commoners, Native Hawaiians, for sustenance purposes. And so individuals would need to have their land surveyed, present claims to the Land Commission, and file their claim by 1854. So you're asking this of communities and populations who basically have a different concept of land, where they live and where they were, basically doing their work, and asking them to sort of fit into this mold of this Western concept of land ownership. So consequently, many Native Hawaiians were unable to meet the requirements needed to obtain the titles and were virtually stripped of the lands they had lived on and cultivated for so long. So as Native Hawaiians lost their lands, foreigners took advantage of the Resident Alien Act and began buying and selling land in Hawaii. And I say all those things again to say, these are laws, these are legislations, the power of the pen, the power of policy and law. I just really, really want to underscore and how that can play in for you as future leaders in medicine, and how your voice can actually make a difference, and how it impacts a swath community of populations through law and legislation, bills, and et cetera. So inequality in the United States is rooted in longstanding behaviors and beliefs. Key word is beliefs, not facts. So in psychiatry, have any of you heard of Dr. Samuel Cartwright? So Dr. Samuel Cartwright was an established, well-respected physician. This is during slavery time, and developed two diagnoses. One was drapetomania, and this was an actual mental illness that caused Black slaves to flee captivity. So if you were enslaved and you wanted to be free, you had a mental illness. This disorder was a consequence of slave masters who made themselves too familiar with slaves, treating them as equals. Again, causing them to have a mental illness called drapetomania. This is real. Dysesthesia ethiopica, another mental illness developed by Dr. Samuel Cartwright. Mental illness that was proposed to cause laziness and disrespect for the master's property among slaves. And of course, this disorder was more prevalent among free Negroes. Now, moving forward, 1960s, 1970s. Walter Bromberg and Frank Simon, they described a specific type of reactive psychosis related to recent social political activities. Of course, this is time civil rights movement, et cetera. So participation in activities like the civil rights movement was viewed as a contributing factor for aggressive and volatile schizophrenic symptoms. This is the 1960s. Their article was published in the Archives of General Psychiatry in 1968. Established professionals, a physician and a scientist, who described this type of reactive psychosis. And I think to really compound this sort of belief or image that, particularly Black men were more assaultive and belligerent. This is on the side here on the left, this is an actual advertisement for Haldol. So they have a picture of an angry Black man with his fist up, and above it, it says assaultive and belligerent. Cooperation often begins with Haldol, a first choice for starting therapy. So this was an advertisement in the Archives of General Psychiatry in 1974. It's not that long ago. So the prior director for the Center for Disease Control and Prevention, she just actually ended her tenure, Dr. Walensky, this year, basically made the public statement that racism is a serious public health threat. So racism is not just a discrimination against one group based on the color of their skin or their race or ethnicity, but structural barriers, or coming back to those social determinants. These structural barriers impact racial and ethnic groups differently to influence where a person lives, where they work, where their children play, and where they worship and gather in community. These social determinants of health have lifelong negative effects. And you can see, as I showed you previously, looking at sort of the roots of these inequities historically, right, can have lifelong negative effects. And these are things that I think you need to keep in mind and think about as you engage with your patients in the future. So they have lifelong negative effects on the mental and physical health of individuals of communities of color. And this is again, Dr. Rochelle Walensky, prior director of the CDC. And of course, the two events in 2020 sort of, I say, re-exposed and re-emphasized inequities that have existed for generations, and an epidemic that was impacting public health. And that epidemic, as Dr. Walensky said, was racism. And I'm sure you all know with COVID-19, there was disproportionate impact of COVID-19 on one community versus the other, not because of some underlying genetic issues, but some people really just had to go out and work. They didn't have the convenience of working from home. They had to go out and work. And so in the process, they're exposing themselves to this infection. And then they may come home and have a multi-generational household. So then they also get impacted. So again, it's showing where you live, learn, work, and play has an impact on your health. And of course, with the George Floyd piece about basically racism and what happened with him and his demise. So the interesting piece is when social factors and medical care are equalized, racial disparities are minimized. So there was a study that was conducted about 2011 by Dr. Tom Leveist, who was the director for the School of Public Health at Johns Hopkins, and his colleagues. They did a study to really try and understand, is it racial disparities or is it social disparities? In other words, when you see someone, you know how when you come in and you see a patient, I saw a 32-year-old African-American woman who presents with X. You put that sort of racial piece on there because in your mind, that's supposed to pull a couple of plugs that kind of give you some ideas of what is this person at risk for? What are you thinking about? But is it really race that's, really causing the things that you're seeing, not causing, but impacting sort of what you're seeing? Is it the fact that it's a African-American woman, or is it where this African-American woman lives and not necessarily that he or she, that she's African-American? So this actually study, it was a comprehensive examination of disparities between Black and white Americans. So they essentially looked at individuals, Black and white, who lived they lived in the same area, under the same social conditions, same economic conditions, and received their health care in the same marketplace. So it wasn't an access issue. They had the same access socially, economically, and then they analyzed health-related outcomes. I looked at hypertension, diabetes, obesity, smoking, and the use of health services. And what they found was racial disparity that you normally see was attenuated or either completely erased when Black and white Americans live under similar conditions. So the sole exception of the study was smoking, where they found that white residents were more likely to smoke than Black residents. But again, when social factors in medical care are equalized, these disparities due to race are minimized. And again, addressing social factors can also reduce healthcare disparities. This is just, several studies support this contention. That if you coordinate multiple types of social services, that can reduce healthcare expenditures or utilization. So there is a positive in terms of trying to address this. So as future physicians, understanding these inequities and how these inequities came to be, the roots of these inequities is important, so that when you do go out and advocate for policies and you're promoting health and mental health for all, you have a very good understanding, a very good grounding of where this came from. And I think the importance of you advocating for policies that's going to promote optimal health and mental health for your patients is very important. And I think these next few slides are going to show how select health legislation actually really did impact mental health and wellness and impacted disparities. So I think in the beginning we had that slide that had sort of the timeline. The first one on there was the Community Mental Health Act of 1963. You have John F. Kennedy. So again, this legislation was aimed at providing different levels of mental health care in federally funded community centers. Now, the advocates agree 60 years ago, this was a very important first step. But at that time, half the plan centers were never built, none were fully funded, and the funding wasn't available over long term. But the good news is that today, what we do have is certified community behavioral health clinics. So in terms of addressing individuals who have mental illness and substance use disorders, the fact that you could provide this care and you can serve anyone who requests care for mental health or substance use, regardless of their ability to pay, their place of residence, or age, is really important and is really a huge step forward. So although in 1963, this was sort of put in place and it didn't quite work, it actually is coming to fruition today. It took a long time, but it did actually come to fruition, and it is actually helping a large number of people. The Patient Protection and Affordable Care Act under the Obama administration, again, more affordable insurance for everyone, expanding Medicaid, and supporting innovative medical care delivery methods. So what about that? So the effects of the Affordable Care Act Medicaid expansion piece on racial disparities has been shown to contribute to reductions in longstanding racial disparities in health coverage. So this is actually a literature review that was done through the Kaiser Family Foundation. And the dark blue bars represents the number of studies that find disparities decreased. And the light blue bar is the number of studies that there's no positive effect on disparities. So it looked at 4 categories. So when you look at insurance coverage, 21 of the studies that they found in the literature review actually found disparities were decreased. 8 did not find this. When you look at access to care and use of care, 10 studies did find that disparities were decreased. 14 did not see it. When you look at health outcome and quality of care, 9 studies documented that disparities went down. 3 did not see any effective disparities being impacted. And then for economic measures, 8 studies found that disparities decreased, and 2 of them did not. So while increased coverage from the Affordable Care Act can help improve access to care and contribute to improvements, coverage alone, as you know, is not enough to eliminate disparities. But the fact that this legislation did actually have a positive impact, and it had a positive impact on a large number of individuals, not just a few people, but again, a large number of individuals. You are going to be seeing individual patients in specific areas. That's fantastic, that's wonderful, and you're going to have a positive impact and do a great job. But getting involved and being an advocate and getting involved in legislation and policy, you can have an even larger impact on what happens with patients, not only your patients, but patients overall. And this is just another example with the Affordable Care Act, how it did address this, as the American Psychiatric Association states in its mission statement, quality care and access for all. So it's a big job, obviously, right? Big journey, but it begins with small steps. And so for you, your first step is to essentially use your voice, right? To advocate for optimal health and wellness for your patients, to bring more awareness to your influence, your circle of influence about the importance of social determinants, and getting involved in advocacy, which my colleague Kathy is going to explain to you in more detail how you can do that, whether it's on your local, state, or federal level. And I like to always end my talks with something to think about. Maya Angelou is one of my favorite people, and she says, do the best that you can until you know better. So today, you know better. You have some information under your belt. You have a historical perspective of why these inequities exist. It's not just a contemporary consequence. You can utilize that information as future physicians, as you're interacting with your patients. So now that you do know better, you can now do better. But you do the best that you can right now. But the more you learn, the better you can be, and the better you can be for your patients, and the better of an advocate you can be. So with that, I'll say thank you and see if you have any questions. This is deep, huh? sorry?
So you can see them on Zoom.
Okay. Any questions? And on Zoom, any questions? Yes.
Isn't that time graph where there were 3 points, and the time between the first 2 points was 45 years? Whether I mean, was it really that long or something?
No, I just chose 3 that people will probably be familiar with because it dealt with the community mental health clinics and the Parity Act. Yeah. Oh, Kathy will show you a number of other pieces of legislation, I think, but that was just to give you a sense of, it's been going on for a while, but it can have a significant impact when it does work. Is there another question? Yes.
We talked a little bit about like the different steps that have got us to today. I'm curious, like, if you could wave a magic wand or pass any legislation or policy that you would like what kind of steps do you think are needed to move mental health equity forward?
I think it's people like you sharing your experiences with your policymakers about why this change is important. I think, again, Kathy is going to talk about how to do that, but I can share with you just from my 20 years at the National Institutes of Health and being on the Hill a lot, those personal stories and your authenticity matter. That's what makes a difference when people can connect with your story. I think being an advocate, you will not only help your patients, but you'll help people in general and communities and populations. So if I can wave a magic wand, I think that the oversight or the lack of oversight and management in the Mental Health Parity and Addiction Equity Act, those loopholes that health insurance companies tend to find and not be able to abide by, I think that would be a huge piece, because I think it will send a message that mental health is health. I mean, mental health and physical health go hand in hand. So one should not be compensated less than the other, because it does sort of send that message as well. And I think that would be a huge step forward. But there's so many other pieces, other policies that could make a difference as well, but that's one that comes to mind for me. Yes.
In regards to the rates that all study, did anybody ever do the contrary, where they looked at higher income neighborhoods and then see if the racial disparities start to become unequal?
I'm not aware of that, but I'm going to look that up. And give me your name or your email address, and I'll send you something. I like those kind of questions. It challenges me. Yes, I'll look that up. I'm not going to like stalk you with your address. But seriously, I want to look that up. Yeah. Oh, thank you, Kathy. Any other questions? Oh, yes.
Why do you think that in the ACA, in the Medicaid expansion chart that you showed, why is there kind of that discrepancy of access and use of care, but not so much like health outcomes?
Well, I think, first of all, with the Affordable Care Act, all the states have not actually expanded Medicaid. So that's a big piece. So they don't even have the opportunity to actually implement any of these things. And I think that's a big piece. See, I think that would really be my answer. I think it's harder to sort of look at the data. And these are just studies, as you saw in the bars. It's hard to look at the data when you don't have the full picture, but this is just based on those states that have had the opportunity to expand. And so this is sort of where we are today. But hopefully other states will have that opportunity to do so at some point, so that we could really provide that opportunity to all.
If there are any other questions, can we take them in the room afterwards? There are also scholarship opportunities for medical students and residents, and we're going to offer snacks in what room?
Yes, I did want to quickly say that too. So for those online, the American Psychiatric Association supports a program for medical students. So medical students who may even think about going into psychiatry. We have a program where it's virtual, so you don't have to leave where you are. It's for about 6 weeks, and it's just an opportunity to get online virtually and hear from various leaders in psychiatry about the different subspecialties. What does it mean to be a CL psychiatrist, a child and adolescent psychiatrist, a geriatric psychiatrist? And you can ask questions. So it really allows you that opportunity to get to know what is it like to be a psychiatrist, as well as we provide a book stipend of $500. The big thing is that you get a free trip to the American Psychiatric Association annual meeting. So you get the flight, you get the hotel, you get a per diem, and it is an opportunity to network. So you'll be networking with other fellows who are there. You'll be working with other undergraduates who come, because we have an undergraduate program as well. But I think it introduces you to the concept of what it could mean as a psychiatrist and what role you can play and how you can really improve the health of the nation. So it's an excellent program, easy to apply. When is the date to apply for the medical student program?
It starts November 1st, so just apply early, even though it closes in March. In addition, as a medical student, I believe you can register with the APA as a medical student at zero charge as a member. So Dr. Blaisdell can tell you, dues go up, so get it while it's free. So it's a great way to also get information about the APA.
And you get assigned mentors. So you get mentors as well. So thank you all for the opportunity to share this information with you. I'm very passionate about this area, obviously, but now I'm going to have my colleague Kathy come up after Dr. Blaisdell introduces her, who's going to really tell you how to get your feet wet in this whole process. Thank you, Dr. Blaisdell. Thank you all.
I just wanted to add regarding access to care. Having insurance does not equal access to care. So as Dr. Maury's nodding her head, as we all know, there's a severe physician shortage, and Kelly Withy has done many of these reports. So more people have insurance, that's great, but we still don't have enough rural physicians, which is one thing Dean Hedges really worked on. And there's so many other pieces to wellness than just getting insurance. But I think that okay, next up we have Kathy Oriana, who's the State Government Relations expert at the American Psychiatric Association. Thank you, Kathy.
Thank you. Hi, everyone. I'm going to try to go a little bit more quickly through my slides, just so we can get to questions. And honestly, this is also informal. I am seeing the Zoom chat, so please, feel free to throw questions at me. As Dr. Blaisdell mentioned, I'm Kathy Oriana. I'm one of 3 regional directors at the American Psychiatric Association. I work on the state advocacy team. Because you all are medical students and sort of at the beginning of your medical career, largely I am making the pitch for organized medicine and why you want to be part of an association like APA, no matter what specialty you go into, because as Dr. James, flagged, your voice is really important. And it's so much easier to get things done when you are well represented and working in concert with your colleagues in your field. So just to sort of level set, I want to hear from you all. How many of you, or you can just raise your hand, you don't have to give me the specific answer. How many of you know who your member of Congress is? It's okay if you don't. This is a judgment-free zone. It's totally okay. All right, we've got a few folks. This one might be a little bit trickier then. I assume that, with those answers, how many of you know your Hawaii legislator? Who represents you in the Hawaii legislature? All right, so you've got a few mentors. I'm just going to point you all towards the folks in the back who might have a sense. So the reason I ask this is, I recognize you all have very busy lives. As students, I don't even know how you're here, because I know that your days are packed. And so being part of an association, a professional association, people like me work in these associations to try to make it easier for you to be an advocate. I'll go through a couple of different examples, but again, we know that your job is to take care of patients. So we're here to help you all become better advocates. So go to the next slide. So like I mentioned, at APA, we have an entire department of government relations. Beneath that department, there are 3 sub departments. We have a team of federal relations. So that's the folks who are representing psychiatrists on Capitol Hill. They are interfacing and negotiating on behalf of our psychiatrists. We often take, what we learn from psychiatry and what is impacting their patients, and take that up to the Hill, and again represent psychiatrists on Capitol Hill. And then there's the team I work on, which is state relations. So here in Hawaii, you have the Hawaii Psychiatric Medical Association. I work closely with Dr. Blaisdell. Dr. Blaisdell and I are on speed dial when the legislature is in session, and we're constantly working and looking out for bad bills that impact medicine, bills that are going to impact access to care. And as Dr. James noted, there are so many pieces of policy that intersect with how with the health outcomes that your patients are going to see, that it's really important to be able to be part of the legislative process. We also have a political relations and grassroots department. So that department operates our PAC. Most medical associations have a PAC. And this is, one way that we are able to support candidates that are in favor of policies, good policies that impact medicine, good and bad, I should say. So again, my team is made up of 4 individuals. We have a director that oversees all 50 states, and then we have 3 regional directors that oversee different parts of the country. You'll see my region there is in blue. It looks like a lot of people, but it's or a lot of states, but geographically, some of these states are really smaller in population, have very different issues than, say, the East, where the population can be a little bit more densely located. So I'll go through a few of our federal priorities. And I love the fact that we're talking to a group of folks who haven't maybe quite decided what specialty you're going to go into. One of our biggest priorities at APA is integrating behavioral health into primary care setting. We often find that that's where patients present. Frankly, there's a big stigma around mental health. And so oftentimes patients will find that seeking mental health treatment is far easier in their PCP's office, in their pediatrician's office, in their OBGYN's office. So how can we support the medical expertise or the psychiatric expertise in those offices? So APA is a big proponent of an integrated care model called the collaborative care model. And you can see on this graphic here, the patient is really at the center of the way this works. The medical provider is typically a primary care doc, a family physician, pediatrician, OBGYN, and they work with a behavioral health care manager to ensure that the patient is getting comprehensive treatment. And when issues around mental health come up, they consult with a psychiatric expert, a psychiatrist, who can help them, figure out how to treat this patient's mental illness. And this is a way that, we recognize there's a shortage of psychiatrists. This is one way where we can multiply exponentially how many patients a psychiatrist can see through the primary care setting. I'm not going to go too far into all of these priorities, but I'll tell you a little bit about, again, how organized medicine and working through your association can get you over that victory line of advocacy. So as you might all have heard, DC is a hot mess. Nothing gets through. We're looking at a shutdown, a possible shutdown in a few weeks. There's very little cooperation. APA, I really respect my federal colleagues who really are amazing at getting bills done on a bipartisan and bicameral level. And that is huge because, again, there is very little to agree on Capitol Hill, but our colleagues have successfully gotten several, this is an example, the Complete Care Act would increase the reimbursement rates for collaborative care. One of the things we often hear is that people don't want to do it because they're just not going to get paid enough money to do it. So how can we help incentivize providers? We're going to increase reimbursement through Medicare for this particular model. And it's been introduced by Senators Cortez Masto of Nevada and Senator Cornyn of Texas. These two, I mean, if there's a Venn diagram, there's very little that they have intersecting in that Venn diagram. This bill is probably one of the few things that they have intersecting. So again, this is an opportunity where, you know, your membership benefit is having that representation on the Hill that actually goes somewhere. It's not just, you know, for show. Another huge priority of ours is enhancing the workforce. I think, you know, I just mentioned we are cognizant that there is a shortage. There is not enough physicians. There's not enough psychiatrists. So we work hand in hand with several of our medical partners. Most recently, this last year, Congress passed a bill that expanded GME slots to 200 more. With half of those, 100 of those being segmented for psychiatry. This was a huge win. And again, we worked in concert with all of our partners at the medical level, on the medical level. And we continue to support additional bills that would address this physician shortage and also put forth loan repayment programs that we know a lot of physicians are looking to benefit from. Dr. James, you know, her whole presentation was about health equity, and there's so much that APA does in order to really look at mental health equity. One of the biggest wins, I think I would say, is APA has successfully lobbied Congress to help fund the Minority Fellowship Program. The program you just heard about for the medical students interested in psychiatry, that is a federal program that, you know, the Congress identified as a need to really get more of a diverse physician workforce in place. And that is a significant win for APA's lobbying. There's a few more bills here that, there's another bill here. I'm not going to read through it because I know we're short on time. But again, there's so many different avenues that we are pursuing, advocating for. Oh, sorry, there was a question. To advance mental health equity. And then one other big priority is around telehealth. This is a huge priority that, you know, really exploded during the pandemic. I think, you know, we saw everyone being sent home, and doctors suddenly were able to see their patients via telehealth through a series of flexibilities that were only going to exist through the pandemic. Several groups, this was not just APA, this was, you know, all across the healthcare workforce, lobbied Congress to ensure that a lot of those flexibilities that were put in place temporarily became permanent. So these included making sure that physicians and other providers had telehealth parity, which means you get paid for the same service you're delivering via telehealth as you would in person, and also coverage of audio only. We were just with the psychiatric residents, and one of them, you know, really spoke up about how much that audio only piece is so important here in Hawaii, where the infrastructure is just not there to really support video only telehealth. And when we're talking about equity, when we're talking about reaching folks who live, you know, in more in less populated areas with the appropriate structure, access to telehealth is a huge tool to increasing healthcare equity. So I'm going to talk a little bit about some of the issues that we've seen at the state level. So I talked a little bit about the federal level. You saw there were very few bills that, you know, we actually are working on and actually supporting and have an actual chance of getting through. That's how Congress works. Everything is wildly different at the state level. In Hawaii here, the legislature runs from January until about the first week of May. So imagine putting together all of the work that Congress does in a period of about 2 years into those 4 months. Things happen very quickly. You can either, it's very hard to pass a bill. It's much easier to kill a bill, but even still, things move very quickly. So some of these are some of the issues that we've seen. Scope of practice is a recurring issue that we see across the states. Scope of practice expansion for psychologists, PAs, APRNs, pharmacists, naturopaths, you name it, we've probably seen it. I wanted to also flag, because we've been talking about equity, I talked about a couple of these already, but the criminalization of medicine is something that we increasingly see across the states. So, that might mean access to gender-affirming care, access to reproductive rights or reproductive health care. We're seeing this across the states, increasingly a number of bills that would criminalize physicians who would deliver care that has been defined as the standard of care. APA has policy that supports both gender-affirming care and reproductive health care, or comprehensive reproductive health care. And at the state level, we've fought several bills that would criminalize physicians. We do this with our partners. It's not just APA out there opposing these bills. But when you think about the mental health impact that this has on patients who can't get the care that they need, it can be pretty detrimental. And to Dr. James's point, it's the power of the pen, right? That even just the discussions around these bills really can impact our patients' outcomes. So I want to flag this just for those of you who are planning on, practicing in psychiatry. One of the main scope of practice issues that we see is psychologists wanting to prescribe medications. On this map, you'll see about 6 states that are outlined in red. Those are 6 states where psychologists are already able to prescribe medications. So they can essentially practice like a doctor out, with a carve out of mental health medications. But you all are in training right now, and that, it's very hard to segment what only impacts the brain. There's a wide impact of those medications. So as we work closely with our district branches, we are opposing those bills, and you'll see those the states where we saw bills introduced but did not move forward here in blue. Hawaii is one of those states, and we are constantly, I think, Dr. Blaisdell, you might know the exact number, but I believe this has been like a 20+ year fight with the psychologists. We're with the psychiatric residents who, really succinctly defined everyone has a role, a really important role in delivering care, including psychologists, and, cannibalizing their profession to do something that is already easily accessible through physicians, APRNs, and PAs is not the solution to getting people more access to care. So here are a few other issues that APA has helped shape with our district branches. I won't go too far into this because we've talked a little bit about how we've focused on this at the federal level. So this is a little bit redundant, but I'll get into how you can be an advocate. So I question for all of you, as you are talking to legislators, it's important to hear or to know that legislators are not experts at most things. Most legislators have a different job. Most legislators are not even doctors. They have no sense of medicine, but they are in the position of power to really impact how you all might practice in the future. So as you think about meeting with a legislator, does anyone have any strong opinions about which of these 3 is most impactful when you're talking to a legislator? Anyone? This is a judgment-free zone. We've deemed it so. It sounds like some of the folks who know their legislators also know the right answer to this question. So it's a bit of a trick question, but statistics and studies are super helpful and compelling to a legislator who might not understand, the deep implications of a specific policy therefore. But stories are what really sticks with them. Today we were sitting again in this other meeting, and we often address questions around involuntary commitment. And on the table in front of me was the actual intake for an involuntary commitment. And I'd never seen one before. I worked at APA for 6 years. I worked on advocacy on this issue for so many years. And it really struck me because I lobby for the APA, and I had never seen what it actually looks like to commit someone. Those stories and the way that policy actually impacts the way doctors practice are far more compelling than statistics and studies. You can always follow up with the legislator with some of those data points, but really stories of how policies impact patients is what's most important and what's going to stick with them. Legislators really need to hear from you. If I haven't made that point succinctly enough, you all are in training. You're about to, you're at the beginning of your training. Many of you will go on to specialize and subspecialize. Legislators don't have that benefit of understanding how patients actually need to be treated. They need to hear from you and they can in multiple ways. How many of you have ever sat through a bill hearing? Again, you guys got some mentors in the back to seek out. So typically in most legislatures, every single bill that is proposed will get a hearing. Folks that are very supportive of bills or very opposed to bills, you'll see each one of them have an opportunity to either submit testimony in a written form or testify orally. They collect that information. My name, if anyone ever wants to Google it, is like in the internet on several of our letters, either opposing or supporting bills, because it goes into a permanent record that legislators have on hand, keep and document for to inform their voting process. There are a few other ways that you can advocate here, but again, acknowledging that you all are very, very busy. One way to start to get to know your legislators, if you are picking up my hints, picking up what I'm putting down, if you want to look up who your legislators are tonight, I recommend you start following them on social media. It's a very small and easy way to start figuring out, what do they care about? How do they communicate? What do they talk about? Do they have a family? Do they have hobbies? Do they care about the issues that you care about? During the pandemic, it was often the way that we found out information before it was even published in an actual official forum. So I will move on to talk a little bit about, if you all want to take my advice one step further and actually meet with your legislators, here are some very quick tips on how to engage them and keep the conversation going. You really want to speak in a conversational tone. I know, sometimes in talking with some of the docs that I regularly am in touch with, we drop acronyms, we drop terms that mean nothing to anyone outside of our world. And that's a really bad habit to have when you're talking to legislators. So it's really important to keep your language simple and conversational. Legislators and their staff often have a lot of things on their agenda, so you want to keep it short. Keep your ask, slip that in right at the beginning. I want you to support Bill X, Y, and Z, or I want you to oppose Bill 1, 2, 3, and really get that in at the beginning. And again, you probably are much smarter than a lot of legislators, unfortunately, that are running our country. You have been in school for 1,000 years. You know a lot more than they do, but again, they have egos, and they'll be more likely to take your feedback if you offer yourself up as a resource, and to the point on this slide, aren't trying to win the smartest person in the room award. And then lastly, we just encourage everyone to have your elevator speeches and your patient stories at the ready. I talked a little bit about how the stories that really stick with legislators. One of the slides that you might have seen earlier, one of the biggest issues that we work on at the state level is prior authorization reform. And I know I've just said those 3 words, and I've lost like 75% of the room because that sounds really boring already. But when we talk about it in terms of the patient impact and patients that have actually been harmed by bad policies, that goes a far longer way with legislators than when we drone on about how bad the health insurance industry is. So thinking about how you want to start preparing these elevator speeches, here are some tips, and I urge you to practice. I have, one of my close family friends, they have an 8-year-old daughter who's very interested in what I do, but like can never actually articulate what I do, mostly because I just send her postcards from wherever I'm traveling to. So she thinks I have like a very fancy job where I fly a lot. And so every time I see her, she asks me what I do, and I feel like I'm trying to further refine what a lobbyist does, to the point where an 8-year-old may be able to one day describe accurately what I do. And I wanted to point out APA's advocacy team has an advocacy newsletter. Again, just a really easy way to start getting into understanding what organized medicine can advocate for. It's open to anyone who wants to start tuning in. Very easy. You can go to this website and you can sign up. I'm happy to share some of these links when we follow up, but we certainly urge you to start getting just acquainted with some of the terminology, some of the priorities. We recognize again that you are going to be very busy doctors taking care of patients, but your voice is really, really important when it comes to policymaking, and healthcare consumes so much of policymaking that it's really important that doctors stay engaged as advocates. So I'm going to stop there. If anyone has any other questions, here's my email. You can feel free to email me. But I'm gonna wrap it up there because I know we're running tight on time. So I'm gonna stop there. Okay. I don't know if there are any questions. I feel like I ran through that and I talked very quickly, but any questions? Okay, I just answered all the questions.
Thanks, everybody. So to sum it up, why do advocacy and social determinants and equity matter now more than ever? Well, we had a long discussion with Dean Emeritus Hedges and Dr. James the other night. And basically, if affirmative action is not going to be on the table, the next thing to look at is learned and lived experiences that make health equity more possible for some people than others. So it's not really about a person's ethnicity or the color of their skin. It's about their lived experience. How close were they to a healthy food store? How far were they from an emergency room? Did they live somewhere in Michigan where the water was polluted? And I think Dr. James and Dean Hedges were both positive and forward thinking in that it's actually might be better in the future if we start looking at lived experience instead of people's ethnicity and color of skin to decide how we can make healthcare more equitable and how we can choose doctors who are going to, forward that plan. So with that, I wanted to add that Dr. James is very generous with her program. You don't have to be thinking about going into psychiatry to apply for these fellowships. In fact, when we were here last year, Dr. James was encouraging students in pediatrics or family practice to apply for this fellowship. You might get money for books, you might get to go to APA, and if you're going to be a pediatrician, meet child psychiatrists who you can network with in the future. Or if you're going to be an OBGYN, meet maternal psychiatrists who you can network with in the future. So please come and join us for snacks in the next room. And thank you, Dr. Omori and Dr. Takanishi, and thank you all for your time.